the PCOS Society because this is my first interaction with this great group of nutrition experts. Well, we are a multidisciplinary society. We have a mix of gynecs, endos, dermatologists, specialists in nutrition, physiotherapy, bariatric surgery, anyone and everyone who deals with PCOS. I'm an executive committee member since its inception, which was in August 2015, under the leadership of Dr. Darusha, who said a warm hello to everyone here today. The goals of the society, in short, is basically to promote academia, research, awareness, and education in the field of PCOS to physicians, the public, and patients alike. So with that short introduction about us, let's go ahead with the proceedings.
Thank you. Thank you so much. Looking ahead to your talks. Thank you.
I take this opportunity to formally invite Dr. Pia for her talk today. Let me give a short introduction about Dr. Pia Balani. Uh, as we know, can I have the same slide again, Prachi, please? Our introduction slide. Yeah, thank you. As we know that she represents the PCOS Society in today's program. She is a consulting physician and endocrinologist at Bombay Hospital and Medical Research Center. She is a diplomat of the American Board of Endocrinology, Diabetes and Metabolism, and also a diplomat of the American Board of Internal Medicine. She has multiple publications, and what is highlighting is her category of awards that she has received. Right from America's Top Physician by Consumer Research Council of America to the Research Physician Recognition Award, American Medical Association, the Stoon and Purandare Prize, and the list goes on and on. With a special interest in a woman's health and diabetes, thyroid, and gynec endo, we welcome you, ma'am, for your talk so that this subject, which is quite relevant to the entire audience, we got to learn and hear from you. Over to you, Dr. Pia Balani Thakkar. Please take over the charge.
Thank you very much, Ruby. May I share screen, please, Prachi?
Yes, ma'am. Now you can share your screen.
Am I visible here?
Yes, ma'am. You're perfectly visible. The slides are visible.
All right. How do I minimize my slides over here? 1 minute. Okay, sorry. Okay. Well, again, good evening, everyone. And like I said earlier, when Niti asked me to do a talk on PCOS, it came to my mind that instead of doing the usual obesity and insulin resistance, etc., kind of talk, which I think all of you all know a lot about, I basically thought to myself that this would be a good opportunity because today we are a multidisciplinary platform to understand more about PCOS, how we blend the subjects together, how we unify what we are all doing, while at the same time maybe putting across the different challenges that we face while diagnosing and managing these patients. So with that thought in mind, what I'm doing basically today is a little bit of an overview in kind of having everybody understand what maybe some of the other specialties are also kind of, doing in the field and to give a broader perspective on the same. So like Niti started with earlier, PCOS basically is a syndrome, a complex metabolic syndrome with ramifications which have a cardiovascular impact, a metabolic impact, a reproductive impact, a psychosocial impact everywhere around. 1 in 5 patients probably entering our OPDs today have PCOS. It's indeed become the epidemic, one of the epidemics of the 21st century. And they say 8 to 13% of women in the reproductive age group have this particular syndrome. But at the same time, what we find is that a lot of our patients are still expressing dissatisfaction with the kind of treatment that they get in clinics. And why is that? That's because I think there are so many multiple presentations, multiple symptoms, multiple windows of entry, be it the derm or the gynec or the psychologist or the nutritionist or the endocrinologist, so many different criteria, so many guidelines, so many tests that we need to do. So it's just become very confusing for the physician in the first place to make the correct diagnosis. No wonder it leaves the patient confused as well. So case in point, what I'm doing here over here today is presenting this small little case, which I want everybody to maybe give a little thought about. And so in your own minds, I want you to figure out what you would do in your OPDs, what you would think of with this kind of patient. So let's talk about a 15-year-old who's come to your clinic with severe acne. She's of course presented to you for the purpose of being overweight. Her menstrual cycles have come every 26 days, and her ultrasound shows an appearance of PCO. So in your kind of scenario, at the back of your minds, what would you think of? Is this PCO? Is this not PCO? And we will discuss this a little further again. So remember, 15-year-old, acne, menstrual cycles 26 days, ultrasound showing PCO. We talk about a different case, and over here again, let's talk about a 22-year-old. So this is a second case I'm giving you a little thought about. She's come with menstrual cycles every 3 to 4 months. She's hirsute, but she shows no PCO over here. So the question is, what would you think of this patient? Does she have PCO? Does she not have PCO? So moving ahead over here, what are we talking about? Ruby, I'm actually going to, can I just sign out for a minute and sign in again? I think I've got a little wrong slide set here. Is that all right?
Sure, no worries.
Yes.
Yes.
How do I stop share on this? Hold on a second.
You can put the video off and probably.
Yeah. Sorry about that, guys.
No worries.
Ruby, are you still with me?
Yeah. Yes. In the meantime, the attendees can, start figuring out what question and answers they have in their mind.
Sure.
So they can shoot. We will have the panel discussion, and of course, we will give enough time for the audience to ask questions. In fact, even I have a couple of questions. I'm sure that will resonate with others as well.
Yes.
We already have Dr. Sarita Bhadirao. She's joined in. And I can see Dr. Malvika Kohli already with us in the meantime.
Okay. So now if I want to share this PPT again, are you all able to see this now?
Not yet.
Are you able to see this PPT, Ruby?
No, ma'am, we're not.
No.
So how do
We
I?
start the video also. The video is
Okay. This is my video though.
Yeah.
And actually I need to share screen on this.
Same way you can share the PPT, ma'am.
I'm just figuring out how to do that.
You can
One
open
second.
that PPT first on your laptop.
Zoom. Yeah, this is Zoom. Zoom is here, see?
Prachi, do you want to guide her?
Did I sign? Okay.
Yeah, ma'am, you can just open that PPT on your PPT on your laptop.
Yeah.
And whenever you do a screen share, it will be very easy for you to share with us.
Okay.
Yeah, we got
Yeah,
it.
it's visible.
Now you can see that?
Yeah, ma'am.
Yeah.
And just do the slide share of F5.
Sure. Okay.
Perfect, ma'am. Yeah.
All right. I apologize for that. Okay. So we were talking about the case over here. So I'm just going to represent that because I noticed that I had changed the symptoms a little bit to suit this talk. Right. So this again, coming back to the case, 15-year-old, overweight. She's come with menstrual cycles, let's say every 2 to 4 months. Her ultrasound shows PCO. So this is the kind of case that I'm guessing would present to your kind of clinic. The question is, would you label her as PCO? Would you not label her as PCO? So I want everybody to give this a little thought and we'll discuss this a little later. Let's move on to maybe a second case. This over here is a 22-year-old. She has come to you for management of obesity. Her menstrual cycle is coming every 3 to 4 months. She also has some hirsutism, but her ultrasound does not show a polycystic appearance. So the question again over here, would you call this patient PCO? Would you say this is not PCO? So in everybody's minds, I know we don't have an audience response system available over here, but I just want you to give this a thought, how you would label this patient. Now, so the agenda for today is, number one, why is the diagnosis so challenging? What are current guidelines for diagnosis and evaluation? I'm going to do a very brief run through of that, run through some basics of treatment, because undoubtedly today, the way we treat the patient is very importantly going to depend upon her presenting symptoms. So treatments is something that we can't encapsulate into, under one umbrella, but at the same time, we're just going to touch upon some basics. And at the end of the day, if we can just maybe get some 2 to 3 maybe take-home messages in by the end of this talk, I feel I will have done my job. So why is the diagnosis challenging, firstly? So like I said earlier, PCOS is basically a complex clinical syndrome. It has at the background of it, it starts off with a genetic makeup, which involves a gene that tends towards PCOS, throw into that kind of ecosystem and environmental and lifestyle trigger. What that kind of causes is a background of insulin resistance, which is exacerbated by obesity into a hormonal milieu, which involves, number one, hyperandrogenemia. What that results in is hirsutism, acne, alopecia, which falls, of course, into the dermatology, Dr. Malvika Kohli's bucket, let's say. Alongside with that, it results in an environment of hyperinsulinemia, which results in the long term then in type 2 diabetes, metabolic syndrome, let's say, which fall into my bucket, the endocrinologist bucket, alongside with, in the long term future, a cardiovascular risk as well, going to the cardiologist in that kind of scenario. Also, at the same time, the hyperandrogenemia, the hyperinsulinemia result in the ovarian follicles in the ovary getting arrested in the follicular phase. This results, therefore, in anovulation, menstrual disturbances, subfertility, which then fall into, let's say, Dr. Sarita Bhalerao's bucket over here, the gynecology bucket. So like we're seeing over here, patients can present in any one of these kind of clinics, but 2 common issues. Number one, at the bottom, like we're seeing, the patient, a lot of these patients, a big, vast majority of these patients, in fact, will have at the background psychosocial issues, body image, self-esteem, depression, and anxiety issues that no matter in whose clinic they reach, it's very, very important for each of us to kind of recognize this kind of problem, talk to the patients about this, because this is an underlying but overriding factor in all of these patients' lives, no matter where they arrive. And of course, one other common factor over here is this overall, the common background, the insulin resistance, the obesity. And that's why for us, the nutrition experts who are going to guide these patients with their lifestyle modification, which for me is, let's say, the first line of defense and the final frontier, again, goes through the spectrum over here, no matter what the patient presents with in whose clinic, this again is just a common underlying requirement for all patients alike. So today, what we need to recognize is that no matter where the patient is reaching, of course, each one of us physicians is going to treat the patient as per the symptoms that they present with. But that is not the end. We really need to dig deeper, because no matter whether the patient presents with obesity, irregular menses, fertility issues, hirsutism, acne, etc., what I kind of think of these presenting symptoms as probably just windows or peepholes into what are truly the long-term outcomes, the long-term bigger complications, the more sinister complications, so to speak, the impaired glucose tolerance, type 2 diabetes, hypertension, dyslipidemia, CV risk, malignancy, depression, obstructive sleep apnea. So when a patient is coming to us with any of these issues, what we kind of need to look at this as is almost like a time at which prevention is possible for these greater problems of metabolic syndrome and the long-term sequelae of PCOS. So for example, in illustration, type 2 diabetes. So this was a study, a very early study. If you go to see type 2 diabetes, these are girls, women walking into clinic for the very first time. While 7.8% of controls had impaired GTT at appearance, 1% of controls diabetes. If you look at the PCO girls, 31% right at initial visit already had impaired glucose tolerance. 7.5% in this group already were diabetic at first visit. That is a lot. Metabolic syndrome also look at nearly 42% of patients in this PCO clinic had already a metabolic syndrome at diagnosis. General population is just about half. Look at the controls, which is just about half of the general population as well. So like we know, obesity will amplify the insulin resistance in women with PCOS. So while women with PCOS already have insulin resistance, when you have the higher the BMI, the greater is the insulin resistance, the lesser is the insulin sensitivity as compared to normal patients. And therefore, the higher the insulin resistance, the greater is the hyperinsulinemia, and obesity again is going to exacerbate the insulin resistance associated with PCOS in itself. It's important to understand that lean women too. So around 30 to 35% of lean women, of PCOS women will be lean in nature. So while the obese patient is the one with the greatest insulin resistance as compared to controls, lean women also have reduced insulin sensitivity, greater than the obese patients, of course, but all the same, it is reduced. So moving on then, why is the diagnosis confusing again? This is because the criteria for diagnosis, so we have the 3 cardinal criteria like we know, the hyperandrogenism, the anovulation, and the polycystic ovarian morphology. In the past, all the different criteria, if you're looking at the 1990 NIH, the 2003, the ESHRE, the APCOS criteria of 2006, all of these are permutations and combinations of 2 or 3 of these 3 cardinal criteria that make up the diagnosis of PCOS. However, remember, none of these criteria in the past have addressed insulin resistance and the metabolic manifestation. Also, very important alongside with these criteria is that we have to exclude the other etiologies of androgen excess and menstrual irregularity, without which a diagnosis of PCOS cannot be made. And why is this? Because there are many other mimics of PCOS. So today, when a girl with so-called PCOS, or with whatever her presenting symptoms are coming in, it's important to understand that there are many other scenarios which could resemble some or all of the symptoms of PCOS as well. For example, congenital adrenal hyperplasia, you have Cushing's acromegaly. So in both of these conditions, for example, a girl could come to you with being overweight and insulin resistant at the same time. Exogenous sex steroids. Today, so many people, so many girls visiting the gym, being given God knows what kinds of mixtures over here. So exogenous sex steroids can also present in a similar kind of fashion. Premature ovarian insufficiency. So a woman less than 40, this is almost like an early menopause. She comes with increasing weight. The problem over here is that she's developing menopause far earlier than she should be, maybe in her 20s, maybe in her 30s, and we are treating it as a PCOS. Obesity in itself is the greatest mimic. Underweight, overexercise, chronic illness, severely insulin-resistant states. So not long ago, I even had a girl who basically came to me with bulimia. This girl, again, was being labeled as PCOS. If you go into the eating disorder that is there at the background, one will pull out far more history and then not treat it as a PCOS the way it should not have been done. Now, in order to diagnose PCOS, it's important, therefore, to rule out all of these other disorders. So, for example, the first thing, for example, pregnancy. A girl comes to you, she's come to you with increasing weight, and she tells you her period was 4 months ago. Well, it very well is possible that she's pregnant. If you treat her as otherwise, you might start advising her with diets to achieve weight loss, which completely is not done when she is in a pregnant state. Similarly, if you think about it, hypothyroidism, hyperprolactinemia, all of these mild kind of subtle disorders, very, very commonly associated with PCOS as well, and should be ruled out at the same time. Cushing's syndrome, so a woman who's insulin resistant, gaining weight again, we've not examined her, treating her as whatever else it might be. A simple examination, you've put her t-shirt up and all you've seen over there are those red striae all across her tummy, which just goes to show that a little bit of careful history taking and examination is key. These tests involve a big, big list like I'm showing over here. But truthfully speaking, all these tests are not necessary if one took the time and trouble to take a history and do a good physical exam as well. And so therefore, PCOS is called a diagnosis of exclusion. It is only when we rule out all of these other disorders can we call the condition PCOS. Now, important over here is that PCOS, the polycystic ovarian syndrome, well, the polycystic ovarian morphology is something that is almost kind of non-diagnostic by itself. In fact, the syndrome in itself, I would almost call it a misnomer. It has to be changed into something else, because this alone is, in fact, the girls that come into our clinics, they'll come with that ultrasound done. They've already read up Google. They've already come to their conclusions with what their diagnosis is, gotten themselves scared, talking to you about, whether they'll get pregnant, what their weight issues are going to be over here. Therefore, that ultrasound alone is really unimportant to start out with. Unfortunately, no single test is diagnostic. Why is the diagnosis confusing? Because there are multiple phenotypes. What I'm just going to point out over here, just to make it easy, is the phenotype A and B. The only difference between them is that you have a polycystic ovarian appearance here. In this one, you actually have normal ovaries. But what is important about these two phenotypes? Well, important to me because phenotype A and B are associated with greater total and abdominal obesity. And that is what is of relevance to our audience today. This kind of group, the phenotypes A and B, have higher risk factors for CVD and diabetes, more relevance for me, of course, as well. And therefore, figuring out all of this also mentally helps us reach the patient's diagnosis alongside with kind of maybe prognosticating what her future might turn out to be. In the adolescent PCOS, diagnosis is in fact even tougher to make. And why is that? Well, the anovulation, the irregular menstrual cycles, the insulin resistance due to an elevated growth hormone, increased ovarian and adrenal androgens, which are going to happen in puberty, the polycystic ovarian morphology, even this at 4 years after menarche is present in 33.3% of girls. It's physiological during early adolescence. So all of the cardinal features of PCOS, the menstrual irregularity, the insulin resistance, the derm features that could appear over here, the polycystic ovarian morphology could pretty much be normal in an adolescent with normal puberty. What is the real difference? All of these features will return to normal at the end of a normal puberty, but remain elevated in PCOS. And that is what makes these labs more misleading in adolescent PCOS. And finally, why is the diagnosis so challenging? Well, because phenotypes, the ethnic variations can be so different as compared to the labs. You talk about a lower BMI in East Asians, you look at the Japanese, Chinese girls, they'll have a small little BMI and this great hair and skin that all of us would die for. In Caucasians, much, much higher BMI, but they still might not have all the presentations of PCOS. And in our kind of population, we have it all. The increased central obesity, the insulin resistance, the diabetes, the metabolic risk, the acanthosis, that is just very, very common in our Indian population. So just because of all of these different challenges, just 2 years ago, the ESHRE, alongside with other different groups, basically it was 37 different societies, rather 76 different societies in 37 different countries came together to formulate the international evidence-based guidelines for the assessment and management of PCOS. I'm happy to say that the PCOS Society of India was a part of this group as well. I'm just going to very, very quickly go through the main 3 cardinal features, because I think in making a diagnosis, this is what is really key. What is an irregular cycle? So just in a nutshell, an irregular cycle is normal in the first year post-menarche, till 3 years, 21 to 45 days, from 3 years till perimenopause, 21 to 35 days is the normal cycle, 8 cycles per year at a minimum. So in an adolescent with irregular menstrual cycles, we need to take it with a pinch of salt, because if they do not meet the diagnostic criteria, we just have to label this girl as at increased risk, and reassessment has to be advised later at or before full reproductive maturity, which is 8 years post-menarche, so that we don't confuse this with pubertal normal changes. The second cardinal feature, a polycystic ovarian morphology on ultrasound. Now again, this, like I described earlier, can be very non-specific. It's variable across the life stages. A transvaginal versus an abdominal ultrasound can give you very, very different kind of readings as well, different diagnosis. Important is that this is not recommended in adolescents less than 8 years post-menarche. So basically we have to think, kind of maybe change our way of thinking, that today a young girl comes to you, does one really need the ultrasound? The answer is no, it's not going to make or break your diagnosis. And similarly, if you have an adult in front of you who has hyperandrogenism and irregular cycles, this again, and you ruled out all the other differentials, your diagnosis of PCOS is made. Again, an ultrasound here is not really needed. And finally, the androgen excess, just touching upon that, the 3 features, hirsutism, acne, alopecia, the 3, the commonest features that we see. Remember that these generally are peripubertal in onset, and obesity contributes to all of this as well. There are a number of different tests available. I think the commonest tests that we see are going to be in our lab set free testosterone, total testosterone, though of course now so many of the labs doing this big comprehensive, a PCOS profile as well. Important is just a few things, which is that if you're doing these tests like testosterone, it is important to do a good quality assay like the LCMS-MS. Number two is that do the test if you only know how to manage the test. Because today, if a person has a slightly higher, let's say a DHEAS value, we often find that this is shoved under the carpet, not really taken care of. So if one knows how to read these labs, do them in that case. Otherwise, doing all of these labs for no real reason also is kind of not the best idea. The number of labs required to rule out PCOS actually is small, and that is where your history taking and clinical acumen comes in as well. Number three, the recommendation is that any kind of anti-testosterone drugs need to be withdrawn for at least 3 months before making a diagnosis. And finally, if the levels are really high, important to understand that we should not be missing out on dangerous diagnoses such as neoplasia, etc. So in that kind of scenario, please do refer to the patient's physician or wherever next the patient would like to go. In terms of examination, well, acne, hirsutism, acanthosis, those are routine things that we will, be able to see. Important from your end, of course, weight, I don't need to go over there further. The BMI cutoffs, 23 for being overweight, 25 is for obesity. Waist circumference measurement, always a good idea to do. More than 8 centimeters, 32 inches for Asian women would be considered an abnormal cutoff. And measuring the BP at least annually to pick up any long-term issues like hypertension is a good idea as well. For metabolic screening, alongside with that acanthosis and truncal obesity, fasting lipids every 1 to 3 years. 75 grams OGTT, if that's tough to do, and HbA1c with the fasting blood sugar would be good. Insulin levels are generally not done. None of the societies truly recommend doing an insulin level, and it's quite inaccurate as well. And however, if the screening reveals CVD risk factors, obesity, cigarette smoking, dyslipidemia, hypertension, IGT, lack of physical activity, these women with PCOS should be considered at risk for CVD. Now, important again is that all professionals that deal with PCOS should understand that regardless of age, the prevalence of GDM, IGT, and type 2 diabetes is 5-fold in Asia. It's significantly higher in PCOS and risk independent of yet exacerbated by obesity, and glycemic status therefore should be assessed at baseline in all women with PCOS and thereafter every 1 to 3 years. Women planning pregnancy, of course, again should be evaluated with a 75-gram OGTT as well. The WHO criteria, like we all know over here, an IGT 140 to 199, diabetes more than 200, impaired fasting glucose, here are the cutoffs. Why I wanted to mention this is that when we are all asking for that big, huge list of labs, very often patients will come to me at some later date and I tell them that you are pre-diabetic and have been so for a while now. And the patients will often say that I've been getting these labs done time and time again, but nobody's really told me about this. So there I just want to make a point that if in case labs are being ordered, it's important to understand how to read them and counsel the patients accordingly as well. Other assessments for PCOS, well, obstructive sleep apnea, depression, and endometrial cancer. While all of these have a much, much higher risk in PCOS, obesity independently has a higher risk of the same. So talking to your patients about symptoms of maybe snoring, daytime somnolence, feeling depressed, etc., bleeding after menopause, etc., all of that is important as well while talking to your patients at the same time. Management of hirsutism, the only thing I want to point out over here from a management point of view is that weight loss is key everywhere. So with regards to management, whether it's mechanical hair removal or it is the various hormonal therapies as well, what one starts with always is weight management. The same goes for regulation of menses. It always is going to start with lifestyle modification and weight loss. Metformin, of course, is we We use it because that's what's targeting at the root cause, the insulin resistance. Generally, one would start with a 500 to 1000 BD. You can do a 6-month trial, which is reasonable for the improvement of menses, and then go on from there as it's considered necessary. Inositol, I don't use it very frequently myself, but maybe our gynecologist maybe can give us some opinion on that for the regulation of menses and for fertility issues as well. And of course, the other management that we usually use for menses regulation is with contraceptives and progesterone withdrawal. For fertility issues, again, the only thing I want to point out, weight loss will result in serum testosterone reduction, in resumption of ovulation, no matter what the other treatments are, weight loss remains first and foremost. So coming back to our little question over here, this 15-year-old, she's overweight, had come to you for being overweight. Her menses were every 2 to 4 months. Her ultrasound shows PCOS, polycystic ovarian morphology. So the question over here, is this PCO or is this not PCO? Well, this girl is 15 years old, not yet reached reproductive maturity. The ultrasound over here, this kind of morphology can be common at the age of 15 years, as a result of which, if her menstrual cycles are the one thing, and even menstrual cycles, like I said earlier, can be haywire for a girl who's just 1 year post-menarche. So this over here is not PCOS, and one needs to understand not to counsel the patient in that way. Maybe if one feels that the risk is high, you can label her as an at-risk child and follow her up in that direction. The second question I had posed to you, this was a 22-year-old with obesity, menstrual cycles every 3 to 4 months, hirsute, but no PCO on ultrasound. Question was whether she had polycystic ovarian syndrome or not. This one does. So the point I want to make over here is that even though her ultrasound does not show any polycystic ovaries, this girl with irregular menstrual cycles and hirsutism, as long as, of course, pregnancy was ruled out, let's say, because she's maybe gaining weight, and let's say if her LMP was 4 months ago, the first thing we need to rule out, of course, is pregnancy if she's sexually active, etc. But provided all the differentials are ruled out, this girl would be called a PCO. Finally, with regards to the long-term consequences, this is how all our patients are exercising nowadays, not even that. So at the end of the day, telling the patient that your health is in your hands. All the long-term consequences of PCOS are avoidable with lifestyle management, and the time starts from that early time when the patient is meeting you very early on. That's when the prevention starts off. So with regards to the clinical approach, we identify, we investigate, we tackle symptoms. And all of us are doing this with whatever the presenting symptoms are. But all of us, each and every one of us, has to then take upon ourselves to educate these patients and prevent long-term consequences, because the onus of that is on each and every one of us clinicians that the patient is meeting. Finally, the final message, this is, like I said, the most common endocrine disorder of reproductive age group, multiple phenotypes, multiple criteria, multidisciplinary. Monitoring for cardiovascular and diabetes complications, reproductive cancers is a key part of management. And of course, the most important way of improving fertility and prevention of DM in patients with PCOS remains diet and lifestyle change. So let's all take this opportunity to educate and empower our patients and prevent those long-term issues. Thank you very much.
Thank you so much, Dr. Yeah, it was indeed a very, very, very insightful, really, really a very good talk. It made so many things very clear. I think it all begins with the diagnosis. The minute you go wrong, that the line of treatment varies from there itself. And you kept saying that lifestyle intervention is very, very important even before you prescribe the medical intervention to them. And as we know that lifestyle intervention includes both diet and exercise, and today we have both the experts with us. We have Vanita to tell us what exercise would be best for them, and to know about what is the right diet. We amongst us, amongst all the nutritionists, we also have Niti Desai who will give us a little more idea. But I think what you said was really, really very important. It's not only the responsibility of the doctor or the patient to understand. It's also important for other uh, people in the team with the multidisciplinary approach to understand how to manage this. So I think we will come back to once again during the Q&A session. A lot of people have already started putting in the questions. first we'll hear out what Ms. Niti Desai has to say, and then we will go back to the panel discussion and other things. Once again, I thank you very much, Dr. Pia, for that wonderful, wonderful, wonderful talk.
Thank you, Ruby.
Niti ma'am, are you already there?
Yes, I am.
Yeah, so let me take this opportunity to introduce you formally as a speaker now. Ma'am is a very renowned nutrition consultant who practices in South Mumbai, and we know that she's attached to Kambala Isla Hospital for the last 17 years. She is currently the joint treasurer of IDM Mumbai chapter, and she also serves as a secretary at the Association of Diabetes Educators. Ma'am has been the official nutritionist Femina Miss India 2008, and with her immense number of years of experience, I'm sure she has seen lots and lots of PCOS patients. I request Niti ma'am to kindly educate the patient about the role of nutrition in the management of PCOS. Over to you, Niti ma'am.
Thank you, Ruby, for your introduction. And if I can share the screen now. Okay, it does not. Kasuri does not, it says who can share, all panelists, who can share, start sharing when someone else is sharing. It's not allowing me to share.
Prachi has already stopped sharing, so now maybe you can try again.
No, I still can't.
Okay.
It says, okay, I can now. Yeah. Can you see the screen?
Yes, ma'am.
Yes.
All right. Yeah. A very good afternoon once again. After an excellent session by Dr. Pia, we're going to be talking about the nutrition and PCOS. Just give me a minute. It's the wrong one. Just give me a minute. I'm going to just sign out and sign in. Ruby, you could perhaps start with the panel discussion, some of the questions.
Yes, ma'am. You can put your video off. In the meantime, I have a
Yes.
couple of questions. I will wait for your talk to get over to begin the panel discussion, but probably there are two, three questions that I would like to ask on behalf of the audience to Dr. Pia. Dr. Pia, are you still there with us?
Ma'am, you're mute. Could you please unmute?
Dr. Pia Balani, can
Yes,
you
I'm here.
hear
Yeah, I'm
us?
yes.
Yeah. So, ma'am, I was supposed to ask you this question during the panel discussion as well, but let me, ask you right away. There was a big list of tests which you mentioned, which may not be required for all patients, whether it is not required or whether it is cost cutting or whether a patient who is non-affording. Could you just list out which are the two, three very important tests which may be essential to diagnose the person to be a PCOS?
So, like
Only
I said,
selectively.
PCOS is not diagnosed by any test. What we are basically doing is ruling out the differentials of PCOS when we are doing those tests. So that basically just given the, let's say, the commonest problems in the general population, which need to be ruled out, which also kind of mimic PCOS. Now, this Ruby, like I said, I am not going to name something like a serum cortisol, but that will get ruled out to a great extent, let's say, by a physical examination. So there is no list of tests per se to rule out to kind of rule in or rule out. Basically, it is about physical examination and history as the start. Then the test that generally one would do. If I was to give you a simple list over here, it's basically going to be a TSH, prolactin, FSH, a total testosterone. Now, again, remember over here, if a woman actually has clinical features of hyperandrogenism, the guidelines suggest that we do not need to do biochemical testing. So the free testosterone, the total testosterone, all of these are notoriously inaccurate tests. As a result of which, if you have clear-cut features of hyperandrogenism, testing for biochemical hyperandrogenism is not required. However, if there is, for example, women who are maybe excessively hirsute, you just have, some other, like a little deepening of voice, maybe a little more muscle mass, etc., you might actually be looking at an androgen secreting tumor, due to which we also will do a testosterone level. So again, coming back to the list, a TSH, a prolactin, and FSH, which is primarily to rule out premature ovarian failure. You're doing a testosterone over here. If a source of adrenal androgen is suspected, a DHEAS. We don't really have that much congenital adrenal hyperplasia. So though one might consider doing that, it would be one of the tests which one would maybe keep at the bottom of the rung. Important, again, from the point of view of long-term issues, doing your HbA1c or a 75-gram OGTT with a lipid profile, in fact, is very, very important, because it's not only about making the diagnosis, but looking at the long-term complications at the same time. And I think Niti is back, so I will zip it for a while, Ruby. Yeah?
Thank you for that precise answer. But let me see if she's able to share. Otherwise, I have two more questions for you.
Sure, sure.
Yes.
Niti ma'am, are you ready with your slides?
Yes. Now I was, again, it says the same thing. Prachi, should I be able to?
Niti, you can email it to Prachi, maybe.
You can email it to me and I will share it.
Yeah. So Ruby, you could continue with the questions.
Okay, ma'am. Yeah, you
So
can.
Ruby, did I answer your question? I know I went a little around the block, but
No, it was that's exactly what PCO is. It's not as simple as getting to the diagnosis. It's actually beating around the bush to reach the correct diagnosis.
that
But
is.
since you've been saying one question which is very simple, but I think a lot of people would want to know is hyperinsulinemia same as insulin resistance, or both are different? And where does PCO stand?
Basically, hyperinsulinemia is a result. It is the consequence of insulin resistance. So hyperinsulinemia basically means that due to the inefficiency of the insulin action, the beta cells of the pancreas are therefore manufacturing more and more insulin. The job of insulin primarily is to induce glucose uptake in all the cells of the body. Majority of the utilization of glucose happens at the level of the muscle. So basically, in short, the glucose uptake by the muscle is promoted with the presence of insulin. If in case there is insulin resistance, there is a barrier to the action of insulin, as a result of which the pancreas, the beta cells, are generating more and more insulin in order to overcome that insulin resistance, in order to get the glucose into the cells.
That was good physiology insight for us. But since we're talking that this is insulin resistance and hyperinsulinemia, you mentioned that height, weight is very, very important. But do we also look at total body fat percentage? Because we also see lean PCOS in men.
So
So their BMI may be normal.
why I did not bring that, because I feel everybody at every level does not have the means and the ability to check body fat. If you have that ability, sure. I think all of these ultimately are parameters to help us, and more importantly, the patient also, to kind of get a little bit of a push to improve. We always need some kind of, visible outcomes to help us strive towards a certain goal. So today, if in case that turns out to be your waist circumference, or it turns out to be your BMI, or your weight, or your body fat, all of these can be used as parameters per se. Across the globe, the easiest measured in every clinic, whether it is your clinic, my clinic, the cardiologist, the gynecologist, each and every one of us needs to be measuring, or the dermatologist for that matter. Everyone can be monitoring simple parameters like the waist circumference and the BMI, as a result of which these are just simpler parameters to keep as a long-term follow-up trend.
Okay. So going back to the earlier question about insulin resistance, what would be when the patient look at the results, the lab reports, they see the the result of the insulin levels, fasting and PT, may be normal, but towards the higher end. And they may say it is normal, but we see them going and becoming more and more insulin resistant. What would be the cutoff where you think they're on the safer side or they are becoming more and more insulin resistant?
So basically, insulin levels, it is not even recommended to do. None of the guidelines recommend doing that. Insulin resistance, we know, is at the background of PCOS in 50 to 80% in our population. I would say it's closer to the 80%. By worldwide figures, they say 50 to 80. But we as a population are insulin resistant in general. If you have a woman who's presenting to you with acanthosis, with skin tags, with abdominal obesity, you know that the insulin resistance is already there. Therefore, doing a test like fasting insulin, number one, not recommended. Number two, not even necessary. If PCOS is there, it's most likely going to be there. Again, agreed that in terms of numbers, some people before getting onto metformin, the diabetes drug as they would call it, before getting onto that kind of thing, they need to see some maybe visible evidence why you are justifying something for that. So even as far as cutoffs go, cutoffs across are going to be different. Some people will describe a normal as 2 to 6, and you'll see normals going all the way like 10 to 20 as well. So in terms of improving insulin resistance, you really don't need to go with numbers. I would possibly use it if I needed to convince a patient to start maybe an insulin sensitizer if my LSM is not working. But after that, monitoring insulin levels really is no use. If the periods are becoming regular, if all the patient's outcomes are overall getting better, why are we even monitoring that? So again, for me, that is again a waste of money. Unless you feel your patient is the kind who needs to see that proof, honestly, completely useless.
Right, but we generally see a lot of patients with the reports, especially
So
when
what
they're
I'm saying is
diagnosed.
don't even recommend the test. To start with, you might, like I'm saying, I needed sometimes to convince a patient to maybe get onto an insulin sensitizer as a follow-up. If periods have gotten better, if the derm outcomes are better, if weight is coming down, why do I need it anymore? I am not, there is no, like we have cutoffs for sugars, that we want our sugar goals to be between this and this. There is nothing like that. Insulin levels depend upon the feeding status. It depends upon age, feeding status, the ability of the beta cells. It depends so much about the accuracy of the lab. Insulin levels are therefore not recommended to do. We've just adopted this,
I think it's very important for us to learn this and no need to refer to those levels any which way. Because
Absolutely.
sometimes that helps in convincing the patient to start an insulin sensitizer. So it becomes very difficult for us to, I mean, for the doctors especially, to convince the patient to begin on that, on any insulin sensitizer like metformin. Do you think that
Right.
is first line of treatment in medical intervention?
No, first line of treatment, like I said, you are my first and last line of defense. I will always tell patients, you do more. I am very happy to sit back and do nothing. So if they follow the whole lifestyle issue, I tell them, I want to relax. You do it. And so at every point of time, we also see when patients are on medications, and I'm sure that every one of us who's dealing with the clinical kind of manifestations of PCOS, be it the derm manifestations, irregular periods, weight gain, or whatever it might be, we know that with PCOS, as long as the effort is on, or as long as the medications are on, you're going to get the results. But once that all goes away, if the patient is not making an effort at her end to incorporate the lifestyle modification into her life, there is going to just be a continuous need for symptom control via medication, be it the OCP, be it the anti-testosterone medication, be it whatever it might be, right? But at the root is basically the lifestyle modification, which is going to help with symptom control to start with, and is going to help with preventing the long-term sequelae of PCOS as well.
So in case you have to put the patient on metformin because the LSM doesn't work,
Yes.
so suppose the patient conceives in a couple of months, then
Yes.
would you or discontinue the treatment of metformin?
So basically, I think that I would basically discontinue at the end of the first trimester, because metformin in itself has been shown to prevent first trimester miscarriages in itself. So I would continue it till at that point of time and then take a call about whether to discontinue it. Also, point to note is that there's a very, very high risk of gestational diabetes mellitus in this kind of population as well. So metformin sometimes helps to control sugars while at the same time. But otherwise, if that is not a concern, everything is okay from that front till the first trimester, and then I would discontinue it. Sarita might have an opinion over here. Sarita.
Okay, we'll ask her once she's here. I think, thank you so much for answering these questions. Meanwhile, let me check if Niti ma'am is ready with the slides.
Niti's back, yes.
Yes,
Niti?
I am back. I think, yes, technology can be temperamental at times, I guess. Sorry, guys, but yeah, I'm back. Okay, so we are going to talk about nutrition and PCOS. And let me start. So as Dr. Pia said, that PCOS is one of the most common female endocrine disorders in the reproductive age, and the incidence is only increasing. That's what we are seeing in practice, and even worldwide, it's the same thing is being seen, that the numbers are just increasing so much so that they are looking at making it a public health priority. PCOS can be manifested in different symptoms, as again Dr. Pia explained, but the treatment options, no matter what the symptoms are, remain the same. The first line of treatment remains lifestyle modification with weight loss and physical activity, especially in the overweight and obese PCOS patients. And then, of course, the insulin sensitizers and the OC pills and other non-steroidal anti-androgens may kick in. But lifestyle modification is what we need to start off with. And that basically involves a healthy, balanced diet, exercise, and most often than not, weight loss as well. And what we have seen is that even a 5% loss of body weight will reduce insulin resistance and circulating androgens, resulting in relief of symptoms and ovulation. So is there a PCOS diet or there isn't one? Before that, I would just like to bring to your notice that we are all thin fat Indians. We have a lot more body fat and way lower muscle volumes than the other ethnic groups. So this is our kind of the genetics that we are born with, and we can't do much about to begin with. And this is very classically represented in this picture, Y and Y paradox, where our Dr. Yagnik is sitting next to the Western counterpart. He looks much smaller, but the body fat percentage is way higher. And that's not our only problem. Our eating habits, they add to the issue. We are basically a carb-heavy nation, right? We all just eat a lot of carbs. And the START study has shown it very starkly that no matter which part of the country, the carb intake is anywhere from 65 to 70%. And this obviously drives people into metabolic syndrome. So the myth that it was only the South Indians who perhaps had a lot more carbs is kind of busted. All of us eat a lot of carbs. So all in all, the Indian diet is primarily vegetarian. It's extremely high in carbohydrates and very low in protein. So if you have a look at, this is like a typical diet plan, not a plan, but this is like a typical meal plan that people would have in cities especially. And if you see here, except for that katori of dal or dahi, which again, a lot of people don't carry when they were going to work because it's kind of messy, there is no significant protein content in the whole day. It's just extremely carb heavy. This constant carb challenge leads to insulin spikes. The beta cells are into overdrive most of the time, and then over time, insulin resistance develops. So our eating habits are just adding to the issue. And then there is another challenge also. 20 years ago, a cup of coffee would be around, say, 45 calories. And now the same cup of coffee could be anywhere from, say, 330 to 500 calories, depending on what you're ordering, a latte or something else with a lot of syrup. Similarly, you go for a movie, which now we haven't been going for last few months, but we would be having a pack of popcorn, which would be 270 calories. And nowadays, it's the top cost 1,030 calories. So there has been an explosion in the portion sizes, which we need to kind of keep in mind when we talk to our patients. With this background, we did a small study where we tried to look at the dietary patterns amongst women with PCOS in my clinic. And it was a sample size of around 200 plus, which after elimination was around 160 plus. It was basically a retrospective observational study, and it did give us some very interesting insights. So the majority of the women who came for that intervention or for health fell in the age group of 22 to 32 years, so that's the childbearing age. So 68% of the women were in this age group of 22 to 32. Also, 43% of them were on metformin, but at the same time, around 46% were on no medication. So either they were not given any medication, but as we have seen in practice very often, they check on Google, oh, it's a diabetes medication, and they do not take even if they're prescribed. So 46% of them are on no medication. Hypothyroidism was also ranked comorbidity around PCOS, and I mean that kind of makes sense because basically there's a common hormonal axis between hypothalamus, pituitary, thyroid, and ovaries. So hypothyroidism, PCOS, of course, weight loss can't get any easier, and that is what they would always like to believe. But as we know that if hypothyroidism is very well controlled, it doesn't remain an excuse. 92% of the sample size had a BMI about the cutoff of 23. So around 83% were actually obese 1 and obese 2 category. So majority of the population, the population which seeks advice, belongs to this obese category. Another very interesting insight, there was statistically significant correlation between emotional eating and weight and BMI. Nearly 74% of the sample size admitted saying that they do indulge in emotional eating. And this was statistically significant. And we know this. And for practice, we need to understand that it's not only about calories and carbohydrates that we need to talk to our patients, but perhaps we also need to address this issue of emotional eating a lot more aggressively and offer them options. Because women, they don't eat only when they're hungry, but when they're bored, they are depressed, and even when they're happy. So I think this angle needs to be looked at, and we need to perhaps put in give in a lot more inputs to them. And of course, there is always a justification to this. Whenever one is stressed, one kind of tends to have sweets. Another, the numbers came, the population, the sample size, basically half and half. Half of them were vegetarians, the others were non-vegetarians. So it was a kind of a mixed group. And nearly 45% of, again, the sample said that they do eat out once a week, while 24% said that they eat out even twice a week, which is a significant number. 40% of the women reported alcohol consumption. And when it came to clinical features, again, 41% of them had menstrual irregularities. I think other way of looking at it is that when women have irregular periods, they are more open to seeking advice or taking an intervention or any medical intervention. This was followed by acne at 25% as the most common clinical features. When the diet analysis was done, we observed that protein intake was low at around 10%, when we know that 10 to 15% is what we are looking at, the higher the better. This was the lower side of the normal. The fat intake was at 30%, and you know the RD is around capped at higher cap is at 30%. and the fiber intake was just a little more than half. So basically, the diet is characterized by low fiber, high fat, low protein composition. When we delved a bit deeper into it, we realized that the MUFA intake was really low. Okay, the saturated fat intake was higher than the RDA, and the ratio of omega-2 to omega-6 to omega-3, which is supposed to be 5:10:1, was actually 50:1. Right. So again, this was a very good insight, and this would help us in planning our diets for this population. Another very significant correlation was found between acne and energy intake, fat intake, and saturated fat intake. I would love to have Dr. Malvika Kohli's views on this, whether she makes anything out of this correlation, or it's just, again, one of those statistical findings. When the food frequency questionnaire was analyzed, aerated drinks, namkeen, and chocolates were eaten daily by large number of women. So we really need to look out for the hidden fat besides the protein intake, because the fat intake was way, way, way higher. So we need to ask our patients for monthly fat consumption, look out for the hidden fat in terms of bakery products, the intake of khari and butter biscuits, the use of coconut, groundnut, other nuts in making gravies. And if the cook or the house help is cooking in the house, then we definitely need to spend some more time and figure out the oil consumption, because it goes completely haywire. And we would want to know the liters used, the number of members in the family, and the rest of it. So we would need to spend some more time. The traditional Indian plan needs to replace some of the carbohydrates with the protein to step up the protein intake, which basically means all our pulses, dals, for the non-vegetarians, lean meat, and of course, eggs. So in a practical sense, if you're looking at the evening snack options, instead of kurmura, if we just add some chana to it, we are done. Instead of the potato wafers, if we have soya chips, again, we made that switch. So it need not be completely way off and different, which may not be acceptable to patients, but just little tweaking here and it works. Of course, sprout salad, nuts, plain chana, different types of protein khakras also remain a good option. So an adequate protein intake meeting the RDA, which basically is around 1 gram per kg body weight. Even if we address that, we try to achieve that, we will have adequate health benefits and of course weight reduction in the PCOS women. The most common complaint that comes from these patients is that I have read that PCOS causes weight gain, and now you're asking me to lose weight. How do I lose weight in a condition which leads to weight gain? Yes, so weight loss is maybe a little more difficult in this population, but it's not impossible. We need to tell them that, and we have some very solid data on this. So in the US, there's a national weight control registry, which kind of keeps track of people who have lost weight more than 13 kilos, 13 and a half kilos, and kept it off for a year or longer. At the moment, they have 10,000 people as part of the registry with an average weight loss of 30 kilos, and they've kept it off for more than 5 years. So far, what have they done to do this? They've changed their diet and started exercising more. The other common points which were kind of found on studying these people was that they started having breakfast every day. They weighed themselves at least once a week and watched fewer than 10 hours of TV. In this day and age, it's more like the screen time. It may not be TV, but it could be any of the other gadgets. So again, in the Indian context, the breakfast has to be had, but it needs to be a carb protein combination. So instead of the idli chutney, it will have to be idli with sambar. Instead of aloo paratha, it will have to be a vegetable paratha with a katori of dahi. Instead of people just have fruits for breakfast. So again, that will lead to a huge insulin spike. So we need to have fruits along with some dahi or nuts, like a smoothie. Suji chilla could be replaced with a moong dal chilla. So again, as I said, it's just a little bit of tweaking, but that can really help. We need to encourage our patients to weigh at least once a week. In fact, of course, we have patients who are obsessive and who weigh after every meal. But yes, generally, that is what we should be looking at. And highly discouraging sedentary behavior, especially in the new normal, where we are not even now going, a lot of people are not going out, are working from home, are not traveling. So sitting is the new smoking. We need to encourage our patients to be mobile. And we have Vinata today, Vinata Shetty, who's going to give us some ideas to be more active even in this new normal. Lifestyle modification, do we have any other help? So there is a lot of research going on, and there might be certain potential adjuncts which might be of use in the management of PCOS in the future. I want to just talk about them briefly because many times patients ask us, they've gone on Google, checked it out, and then they ask us whether they can use this can be used. So inositol, as Dr. Pia said, she doesn't use it. It has been used since the last decade, and perhaps they have a role to play because inositol acts as second messenger in insulin signaling, and in PCOS women, altered metabolism of inositol is thought to contribute to insulin resistance. So there are two inositol isomers, myoinositol and d-chiroinositol, which are of relevance. At the moment, the overall evidence tells us, a meta-analysis of RCT tells us that we have level 1A evidence of effectiveness of inositol to improve insulin sensitivity. Is there a role for melatonin in PCOS? We all know that melatonin controls circadian rhythm, the sleeping cycle. And I've seen these days, a lot of girls, in fact, taking melatonin when they're taking long flights or even when their sleep is disturbed, they're just popping in melatonin tablets. So again, we need to have some knowledge to kind of be able to talk to our patients. So it is known that women with PCOS have lower melatonin levels, and sleep disturbances have been reported to double in women with PCOS. If melatonin is given for 6 months, there is a decrease in androgen levels and increase in FSH levels. But the current thinking is that in future, melatonin may provide an innovative strategy. At the moment, we do not have enough evidence. Vitamins and antioxidants, we all know that supplementation with vitamin B12 is essential when women are on metformin. So that is important. I think we should check with our patients about that. Should women with PCOS receive vitamin D? We know vitamin D is the hero at the moment, and it is kind of, the deficiency is correlated to hyperandrogenism, insulin resistance, and menstrual dysfunction. And in fact, a study in Jogi has shown that when vitamin D was supplemented in the study group, the insulin resistance actually came down on supplementation. But again, vitamin D supplementation holds promise as a potential therapeutic adjunct in PCOS. Of course, we can definitely make sure that the vitamin D levels are adequate in our patients for various reasons also at the moment. Omega-3 fatty acids, again, has always been kind of discussed. This is a very recent study of, which is a systematic review and meta-analysis. And based on the current evidence, omega-3 fatty acids may be recommended. At least we can make sure that there is dietary intake of omega-3 fatty acids in our patient's diet. Lastly, gut microbiome has been discussed at various fora for various conditions. This bias is commonly seen in obese PCOS women also. So this is something I think that we have to leave for the future, where we may have some more data, and this may be playing a very important role in PCOS as well. I would like to end on note that treatment options that address all aspects of PCOS are required. A prudent choice of treatment options based on patient profile can help improve outcomes. A lot of patients refuse different types of treatment, so it will have to be tailor-made to the person. Lifestyle modification remains the first line of treatment, so we're going to be busy with the PCOS patients. Of course, it is at times notorious for poor compliance, and the use of dietary supplements may come in useful in future as an adjunct in our armamentarium for treatment. But at the moment, we will have to majorly stick to our traditional lifestyle modification. Thank you, and we are open to questions now, Ruby.
Thank you so much, Niti ma'am. You made it clear once again that lifestyle modification is important. But it's really very funny, and these are two sides of the same coin. When a patient comes to us, they ask, "Is there a pill which I can magic pill which I can take so that I'm no more a PCOS? Can you give me a shortcut?" When they go to a gynac and when they see an endocrinologist, they say, "No, no, I don't want to take a medicine. I don't want to take metformin. I think I'll try with lifestyle intervention." But when you give them a diet, they're worried whether can I, reduce carbs or fat in my diet. So it's not easy to manage this condition. So I think a team will be able to take care of. No one person can, handle the situation. So I think the role of a dietitian is important, but the role of a gynac, the role of a trainer, and the role of a dermatologist is equally important because stress, depression, and other things which generally do not, are not clinically considered so much. So I think we must discuss with the other experts who are with us on the panel today. I request Prachi to share the introductory slides of Dr. Sarita Bhalira, who is with us today. Prachi, can you please share her introductory slide? Can you go to the next slide, please, where we have Dr. Sarita Bhalira?
Yes, it's taking a little while.
No problem. We know Dr. Sarita Bhalirao is a practicing gynecologist, and she's been on various forums and societies like the MOGS, and she's been a member of the governing council. She's a joint secretary of FOXY, immediate past president of AMWI, and she is currently practicing and attached to Breach Candy Hospital, Sir Reliance Foundation Hospital, Saifi Bhatia, and Valia Hospital. Ma'am has immense experience in seeing such patients. Besides the gynecologist, we also have an eminent dermatologist with us, who is Dr. Malvika Kohli. Can I have an introduction slide, please? Ma'am is practicing at Jaslok Hospital and Breach Candy Hospital, and she is recognized as one of the pioneers of aesthetic dermatology in India. With an experience of 27 years, she has also authored several books. She has been a cosmetology consultant to Lakme India Fashion Week and Femina Miss India. And she has been featured as the top 10 dermatologist 2019 and 20. She's an advisory board of many dermatology societies. Again, when the patients come to us, we see hirsutism is a big problem. We refer them to a dermatologist because that is a very, very important. It adds stress to the patient, and of course, the whole treatment process includes a dermatological treatment as well. Besides this, we also have Miss Vinita Shetty. Can I have the slide of Vinita Shetty, please? She is a certified Reebok master trainer. She is ACSM and ASM certified trainer. She is a master functional trainer, a rehab practitioner. She's been running fitness centers over the last 25 years. And I'm sure she's seeing patients who are overweight or even lean PCOS. So I think her approach would also matter to us because we keep saying that
Niti?
lifestyle intervention is important. I request all the panelists to unmute themselves so that I can share the questions with them.
No,
Yeah.
I'm kind
no,
of stop.
it's
You can stop sharing the screen, Prachi. I can speak to the panelists directly then. Thank you, Prachi. Let's go back to where we have stopped. So we were discussing right from the very beginning about the diagnosis. I will first begin by asking Dr. Sarita Bhalrao. Ma'am, are you there?
Yes, I'm here.
Yeah. So, ma'am, like we were discussing that not all tests are very important, but only some of the tests are very important. No matter which test is, many a times the confusion is when is the appropriate time to do the tests. In fact, somebody has even asked in the Q&A section, then which day of the cycle is appropriate for the blood tests? Is it any day or a particular day of the cycle?
Some of the tests, for example, the FSH and the LH level, follicle stimulating hormone and luteinizing hormone, should be done during the period on the second day or the third day of the cycle. But the other tests, which we usually do, for example, the thyroid and the prolactin and other things, can be done on any day of the cycle. So depending on what the test is, we have to, specify the day. Again, if we are doing a serum progesterone level, then that has to be done 1 week before the expected period. So that the timing is important. But apart from that, the other tests can be done any day of the cycle.
Do you agree with Dr. Pia that okay, all the tests, entire uh, pro, profile need not be done. It has to be based on the clinical symptoms of a patient.
Yes, I agree. Is Pia going to answer that? Are you answering that, Pia?
I already gave my take on it, so that's all yours.
Okay. So what I feel is that, see, it's not necessary to do all the whole battery of tests. Definitely the most important are the thyroid and the prolactin. If a patient is obviously overweight, we would want to look into maybe the lipid profile and the fasting blood sugar and to see if she's diabetic, pre-diabetic, HbA1c, etc. But as Pia said, that the whole battery of tests is not always required. Even hyperandrogenism, sometimes when it's obvious clinical hyperandrogenism, we don't need blood tests to prove it. Our criteria say clinical or biochemical hyperandrogenism.
Okay. There was one more discussion that we were having with Dr. Pia regarding the, prescribing them inositol or putting them on insulin sensitizers like metformin. Ma'am, what is your take in your practice?
So yes, I think that they definitely have a role in insulin sensitizers, and metformin, of course, is very important for insulin resistance. Regarding inositols, we have less data, though some data has shown that they are good insulin sensitizers. So I feel that patients who have insulin resistance, I like to put them on either inositols or metformin or a combination of the two, depending on the individual situation.
Ma'am, so since we also know that metformin may also help in weight loss, vice versa, we are also looking at OC pills for these patients, which may also lead to weight gain. So, where would you place these two in terms of weight management?
What I tell my patients, one thing is that now we have low dose pills and very low dose pills. And the weight gain related to the oral contraceptive pill is hardly going to be 0.5 kilograms to maximum 1 kilogram. So I don't think that, there's a huge amount of weight gain associated with taking an oral contraceptive pill. There may be some amount of mild water retention, which today with the newer pills is much less than what it was before. So the oral contraceptive pills are extremely good in normalizing hormones, in sort of giving regular cycles. They help even for fertility initially to down regulate and then give them fertility treatment. So I think that we should not withhold them for such patients.
So suppose if
May I come in here, Ruby?
yes, ma'am. Please join me.
Yeah, so this is Dr. Sarita. So this is one of the biggest challenges we face. They have been prescribed by doctors, and they'll say, "Oh, I went on Google, and metformin is for diabetes, and OC pills lead to weight gain. So I'm not ready to take either." And that is where I think this knowledge is going to be very, very useful, that, the OC pills, the weight gain that you are expecting with the low dose pills is very, very less. It's minimal. You can't even talk about it, 0.5 to 1 kilogram. So yes, I think that is useful. And metformin, yes, we have to continuously kind of tell them that it is not it is a treatment for PCOS. It is meant for diabetes. It is also meant for PCOS. It's not like they say if we have to take it, will we have to take it forever? I'm not a diabetic. So these are the constant questions that we kind of feel. So
Yeah,
yes,
Niti,
so-
I think we can tell them that it is insulin resistance, which is then going to lead to diabetes. So if we don't treat it at this stage, it could go forward and cause diabetes.
Right.
Yes.
Yeah, right. So I think along with metformin, what other insulin sensitizer that a patient can be put on is an exercise regime. So that also adds up. It works as an adjunct. So I think that question I can ask Vanita. Vanita, are you there?
Yes, I'm there.
Yeah. So I would like to ask you because we see two kinds of patients. We see obese patients and we also see very lean patients. And for both kinds of patients, generally doctors and dietitians also ask them to start exercising. So first, have you seen such patients who come to you with doctor's prescription? And secondly, what kind of exercise regime would you put them on?
Yes, of course. Both. The not obviously overweight, but still having PCOS. And the solution really is movement. Any kind of movement is advisable. So being more physically active is definitely going to help. A combination of different kinds of activities along with strength training, cardiovascular, Pilates, yoga. It's cumulative. The broader the stimulus, the length and breadth and width of your exposure to different workouts will cause greater, deeper, wider adaptations as well. It'll also prevent monotony and greater exercise adherence. And strength training is one aspect which is really there's a lot of resistance by women to do resistance training, and I think that is the key to unlocking long-term weight loss, because not only will it increase your muscle mass and therefore increase your BMR, your resting metabolism, it's also going to lead to longer weight loss. It'll probably take a little bit more time, but it will result in weight loss and also be able to maintain that weight loss. So a combination of all kinds of fitness components is the key towards this.
So on what basis do you decide that for this particular patient, for example, somebody has written this question in the chat box that a person with 100 kgs body weight comes to the gym with PCOS, how would you decide the weekly protocol? Where would you give more of a weight training exercise regime to this patient or more of cardio activity?
As with most, I mean, it'll be a combination of things to, again, as I said, for adherence, to prevent monotony, but also may not want to start a 100 kg woman on a running protocol or anything that's high impact. So you would want to start with low to moderate activities like walking, cycling, swimming, maybe even, and in adjunct with weight training protocols. Maybe not again an HIIT Tabata straight off the bat, but build towards it. So start with an appropriate that's valid for your current fitness levels and also your mental status as well, what you're willing to do. Some people like dance fitness, some people enjoy the challenge of a strength training class. So we kind of work in accordance to what they're anyways aligned with physically and mentally, and then kind of go towards the next level.
But as we know that PCOS is also a result of hyperandrogenism, where the male hormones are higher side. So women really, some patients really fear to, start with weight training because we can't put them on a cardio immediately. But they worry
I
that,
don't
am I going to become muscular?
That's exactly why I find them resistant to resistant training. However, I don't think we're doing any kind of bodybuilding kind of protocol. We are not taking any kind of steroids to up our testosterone or boost our testosterone levels. So I don't think we are in any danger of increasing our hormonal level to that level. It's just about increasing your muscle mass in a very normal, organic manner, such as to support your weight training protocol. It's not a bodybuilding kind of training protocol that I have in mind.
Yes, so they also think that the protein supplements or other dietary supplements recommended because their physical activity has increased. They wonder whether they should take any dietary supplements or protein-rich supplements.
Well, I think Niti would have addressed this, but as we know, as she mentioned, 1 gram per kg, and if you're doing like a heavyweight training protocol, then you might want to up it to about 1.5, and if you're doing it more often, then maybe 1.7. But I think somewhere between that is your sweet spot. You don't have to resort to supplementation. Supplement is just that, a supplement. If you can take it organically in your diet, then there's no need to supplement it.
Okay. So let me ask this question to Niti ma'am. Niti ma'am, would you like to add to this that, So would we recommend any protein supplement to add up to their daily protein intake, and in which form? Because we know carb intake is very high and insulin resistance is the background of this. So ma'am, could you please give us some insight on this, Niti ma'am?
I think she's muted.
Okay, I mean, I think to just answer that question, if I may, a
Yeah,
supplement is, yeah, sorry, go ahead, Niti.
no, we finish it off, Vinata.
Yeah, Niti, I think what you would say as well, a supplement is needed if you're not getting it in your dietary intake. Then only do you need a supplement. But if you can get it organically through your food, that would be your first choice. And that's the route to follow. And
Yes.
only if you're unable to meet it dietarily would you want to add a supplement. Niti, what do you say?
So a lot of times, people don't have, they either don't have the time or they don't have the expertise to kind of cook the elaborate meals.
Right.
That is the time, that is one place where we may suggest a protein supplement as an evening snack, instead of having the vada pav or the samosa in the office.
Right.
Protein shake or a protein supplement that might do the job. It's much easier. Also, I think the other important point to make, which is, I think, is very important, and what Vinata said, is that even when you work out, maybe at the workout intensity is very high, then also 1.7 is good enough. I have seen a lot of people taking body weight just, they're just going to the gym and they have been advised and they have stepped up their protein intake tremendously. Very often, most of them don't know that the protein also is, the nitrogen is going to be deaminated and the rest of the skeleton is going to be converted to fat. Protein cannot be stored in the body. So just because protein is good, it's not that more is better. I think this is also something that we need to educate our patients all the time.
True.
Correct. So Niti ma'am, there's one more question. Like you rightly said about the snacking, there's somebody in Dr. Vikram who has asked this question, that the issue is the evening snacking. He's been trying to control the snacking behavior of his patient, but he needs some options, that the patients do snack but on healthy one. And how do we manage this?
Yes, so there are some very quick options also. Like an egg white omelette or even a pot of yogurt, a protein bar, even our very humble chana. If it is possible, you call for a chicken tikka or paneer tikka if you're, in an office where there's the restaurant around. So it is not necessarily that it has to be vada pav and samosa. There are more and more healthier protein-rich options available. And if not anything, as I said, you also get these protein shakes in kind of single serve sachets. You just need to empty them in a glass of water, stir it, and have it. So if you can carry a sprout salad from home, nothing like it. Otherwise, we would go for this quick and easy options.
What about a fruit?
So he is, I think, looking at more protein-rich snack options. So yes, so these were the options, protein-rich snack options that I talked about. Fruit, of course, is a snack, but very often, at 6 o'clock, that doesn't satisfy a lot of people. They're kind of very hungry. At 6 o'clock is a dangerous time. And if you do a bit of protein, that kind of really takes you through till dinner.
Hello, Jayashri here. Niti, can I add something to your answer?
Sure.
Yeah. So since we are talking about the snack time, which is actually the killer time, so to say, because you manage to do everything right throughout the day, but it is that evening time which makes everything go bad. So what do you think about having nuts like say walnut or almonds, of course to those who can afford, or things like groundnut as a snack, because that serves both the purposes and it gives you good amount of micronutrients also, and it gives a feeling of fullness.
Yes, so nuts, of course, but it will have to be an ounce of nuts. You can sit with a
Correct.
jar
Portion control is
open.
always
Yes,
an
portion control
underlying
is
thing.
very, very important. And you know, not people tend to take in a lot more, but a mix of peanuts and chana would be very good. Very easy, very economical and handy.
Walnut, I suppose, should do the trick. Walnuts and almond, because it has some amount of
Yes,
fat as well, so that gives that feeling of fullness, basically.
absolutely. An
Yeah.
ounce of nuts.
Yeah. I think we have so many questions about the diet in the chat box. We'll come back to you, Niti, once again on those diet related questions. What I want to understand is if the weight loss is achieved by a patient, does it reverse PCOS? Does it take care of the hirsutism? Does it make the woman more fertile? Does it help the watch the hair fall? All these things, are these reversible? May I ask this to both Dr. Pia as well as Dr. Bhalera? If you have any observations or comments on this, does it take
Yeah,
care
you
of
go
both?
first.
Or I can also ask this to Dr. Malvika if she has seen such observations, because with weight loss, does the hirsutism get
Yeah, you
better?
need to unmute.
Yes, I did. Malvika, why don't you start first? Because a lot of your derm manifestations is what we've been asked about.
Sure. So your question was that does hirsutism and acne reverse with improvement in the lifestyle,
Yes, with the reduction in the body weight, especially.
with reduction of the body weight? Well, it's a little complex out here. You may see an improvement in the acne for sure. You will also see an improvement in terms of skin texture, in terms of the hyperpigmentation, and or the testosterone excess signs. Acanthosis nigricans will definitely improve, especially in the facial area as well as in the neck. Later, the underarms and the groins improve. But what doesn't improve necessarily is hirsutism. Hirsutism can be pretty stubborn, and the patients can. But what may improve with hirsutism is that they may be more responsive to the laser hair removal because they don't have so much stimulation of the hair follicles anymore. So they'll still need many more sessions, but they will at least show incremental improvement. And lastly, about hair loss, female pattern hair loss may not necessarily improve with lifestyle improvements again and weight reduction, because that doesn't mean that you can regenerate the hair follicles that have shrunk, that have gone into telogen phase. So you need something to activate them back into growing, and that is the anagen phase. And not necessarily does lifestyle improvement help to decrease testosterone sensitivity at the peripheral level. So we have endogenous testosterone production, peripheral conversion, and something called end organ hypersensitivity, which is your oil glands, sebaceous glands, and your hair follicles can be inherently sensitized to your own testosterone levels, and also your insulin levels and the IGF-1. For us, the IGF-1 factor is probably the single most important factor that upregulates many processes for acne, as well as for hair loss, as well as for hirsutism, and the DHT pathway. So if you keep all these in mind, androgen, to be able to get improvement even with PRP, even with topicals, even with and some patients need that anti-androgen low dose to help. This would be an overview. But acanthosis nigricans improves beautifully.
Okay. I'll come back to you, Dr. Malvika, but can I have Dr. Bhalera?
Yeah, what I think is, we've observed that even with a 5% to a 10% reduction in body weight, ovulation improves, cycles come back, and fertility does improve. So for here, when you're looking at fertility, we're looking at cycles, we're looking at pregnancy outcome. It makes a dramatic difference to bring down, when the weight comes down.
Well, the same holds true. So you're going to get improvement in insulin resistance. However, PCOS, insulin resistance is an inherent part of PCOS. Obesity exacerbates that insulin resistance. So the correction of weight basically can, remove that layer of insulin resistance that's added on by the obesity. But because insulin resistance is there in the background, you might not get a complete reversal.
Ruby ma'am, we can't hear you. Ruby ma'am?
She needs to unmute herself. She's muted.
I think maybe her network is an issue. So there is a question from the audience about,
yes, so I'll take over some of the questions. Who asked, I have been diagnosed with PCOS, but the only symptom I have is irregular periods, that too once in 6 months, and weight gain. So am I correctly diagnosed? I think that's what Dr. Pia discussed in great detail.
Yeah.
Yes, doctor. Sorry.
No, so here we have we have very clear-cut criteria. We have evidence of anovulation, irregular periods, and we have maybe PCOS on ultrasound. So this is falling into the criteria of polycystic ovaries, PCOS.
Right. Talking about insulin levels, please tell me what does that indicate if insulin value is 83 and 200 is my cholesterol number. I'm a 25 years old female.
So that's a fasting. If that's a fasting insulin level, it is indeed high, which means that it will need to be evaluated further. Getting sugar levels done alongside with insulin levels is also key, because insulin levels correlate with the feeding state. A cholesterol level of 200 per se, a total cholesterol alone, is not good enough information. One will need to find out the components, which is whether this is contributed to by the LDL, HDL, triglycerides, etc. So a breakup of the cholesterol is very important to figure out whether the 200 is significant or not.
Great, thanks. Vinata, in this new normal where young girls are now not going to schools and colleges, so there's further drop in activity level, some ideas for working out? Vinata, are you there? Perhaps she is not able to.
Maybe
Meanwhile, Niti ma'am, can you answer this question that somebody is asking? Do they need to take gluten-free diet or lactose-free diet? Because a lot of people go dairy-free also when they get diagnosed with PCOS. Is there any correlation?
So it is, at the moment, it is almost fashionable to go gluten-free and dairy-free for everything from IBS to PCOS to right. So of course, if you cut down gluten and you cut down dairy from your diet, there will be weight loss, because you're cutting down the whole an entire fruit group in terms of dairy. And when you go gluten-free, you're obviously eliminating most of the junk food in terms of the pasta and the pizza and the noodles and the biscuits. So there will be weight loss. But gluten-free diet for PCOS, I mean, in that sense, there is no correlation. But we anyways encourage people to try other cereals and millets and grains. And we have a whole variety of them, from jawar to bajra to nachni to rajgira amaranth. So yes, definitely wheat can be replaced with these much more healthier, high fiber grains, which will give greater satiety. Going dairy free, if you are a non-vegetarian, I think it's a choice because you will still get your protein from the other food groups, though calcium can still be a challenge. Vitamin B12 still manageable, but calcium could be a challenge which we could work around. But if you're a vegetarian, then going dairy free needs very careful consideration and maybe a visit to the dietitian so that it is the vegan diet is kind of planned well. Otherwise, you run the risk of, lowering your protein intake and lowering a lot of your vitamins and minerals.
Niti, may I add a little bit on diet and acne?
Sure.
So, they now, the newer understandings for acne is that it's all about inflammation. So it's all about inflammation at the oil gland, sebaceous gland, and that is because the Western diet with saturated fats and refined processed sugar and simple sugars, as well as with more of refined carbohydrates, activates the mTORC1 and the FOX1 receptors. And these, therefore, when they're signaled, then we can get inflammation of the oil gland, and then the keratinocytic activity along with IGF-1 together does cause, including dietary, skim milk and dairy, all of these together does cause an upregulation of these receptors and therefore of the sebaceous gland and therefore acne. So these two pathways through FOXO1 and mTORC1 are now known to cause acne through this kind of diet and dairy and milk. And this also they have studied for protein supplements and artificial protein supplements, and they have found this also to be one of the causes for acne. So there were a lot of questions on dairy and skim milk and for acne. So now there are papers out for this also. So now this is not true for everybody, however. This is not true for everybody. But this is true for some people probably who are prone to this, probably with a PCOS background, more so. So it's not true for the general population, but definitely those who have an androgen receptor issue.
Okay.
Right. So maybe we could, they could try a dairy-free diet for a certain period of time and see whether, it is benefiting.
Yes.
That might be the way out.
Yes, I think first we tell them to stop skim milk. We tell them to have more of paneer, chena, and yogurt, and try and avoid, especially things like milk-based products, which are in Indian sweets, and ice creams, which are also come with a lot of sugar in them. And we start that way, and then we tell them to wean. If they see an incremental improvement, then we tell them to wean off more dairy, because it's very difficult for an Indian vegetarian to go off dairy completely, initially at least. Almond milk, I find, in the younger generation has found a lot of popularity. They like to have the smoothies and things like that. So I think almond milk has found quite a big way, even more than soy milk, because it's more palatable to taste.
Yeah, that's right, Malvika. The only issue there is that the protein content of almond milk is very, very low compared to the dairy milk. So soy milk has a better protein content than almond milk, but as you said, the palatability is a big issue, and soy milk never kind of took off in a big way in India.
Exactly.
Yeah, that's true.
Okay. Going back to Dr. Bhalerao now. Ma'am, there's a question from attendee. Is it normal to have a cycle less than 28 days or say about 20 odd days? Or is it okay to have cycle anywhere between 45 days to 60 days? Is that okay or is it a sign of
No, so we see average cycle is 28 days plus minus 7 days. If the cycle is less than 21 days or more than 45 days, it definitely needs to be investigated.
Okay. One important question is there any concern of PCOS after a childbearing age?
Yes, PCOS can present at any time, and it can, have different presentations. So even after childbearing and after the family is complete, we see women in their 40s who have PCOS and develop hirsutism, irregular cycles, and have insulin resistance. Even at menopause and close to menopause, they can have problems.
Okay, so it's not only at the younger age.
No.
Many women with irregular cycles must.
Yeah. So there are problems.
Okay. There's one question which says, can insulin resistance be present at birth to a neonate if born to an insulin resistant mother?
No, I don't think so. That's not possible. But if the mother is insulin resistant, there is it's called fetal programming, where the babies in their later life are more prone to diabetes, metabolic problems, and heart problems. So it is intergenerational. So therefore, it's very important that we, control even diabetes in pregnancy, because we know that it has long-term effects on the baby.
Okay. I'm just seeing if there is bleeding during ovulation PMS be considered as having irregular periods. I don't think so, right?
No, I think they're different issues.
Okay, correct. Is there anything called a seed cycling theory?
Sorry,
Uh,
what? I'm
this
not
is for
aware.
Niti ma'am. This is for Niti ma'am. Niti ma'am, can you elaborate on this?
What theory?
Some
Sorry.
seed cycling theory. Somebody has put this question. Um, in which context this participant is asking? I don't know if you are aware of seed cycling theory.
No. I mean, is this about no?
This is just a single question here.
It's
So
about
I think we have asked answers most of the question, but one question to Dr. Malavika. Ma'am, how do we deal with hair fall? Because a lot of patients start taking
Sure.
biotin and other supplements, assuming that they'll get better hair growth hereafter. Can you please elaborate on that?
So hair fall is of two types, right? One is hormonal, which is female pattern hair loss, which is in the crown area. Could be either frontal, could either be vertex or crown area, or it could you preserve the frontal hairline and only have it posteriorly in the vertex and crown area. That's female pattern hair loss, which is actually female pattern balding. And it is activated by DHT, changes the Wnt pathway, and therefore requires a different management plan where we ask the patients to do their hormonal profile. We rule out PCOS as the first factor. It could be due to other, just sometimes their DHT, dihydrotestosterone, is raised. It could be due to a higher prolactin. So it has a hormonal background. So you treat the hormonal background, and you also may have to give finasteride or aldactone, or nowadays we give lesoflutamide, but we just sometimes have to treat them with an antiandrogen along with minoxidil and along with hair growth factors. And you can also think about PRP. You can think about a new technique called Regenera, dermal micrografts, and eventually some women go in for hair transplant. Then you have a second segment of hair loss, which is more general, called acute telogen effluvium, postpartum, post an event, post weight loss, or chronic telogen effluvium, which can happen with ferritin, B12, and D3 deficiency. And as Dr. Niti brought out a very important point, the gut health or the gut microbiome. So the gut microbiome definitely has an impact on the skin microbiome. It is now known that they both interrelate, and D3 levels and ferritin, I would say, are very important. That's when we really test these two, and correction of these brings about very good improvement in general hair loss. So now new understandings in hair science say the following. One, that microfollicular inflammation of the scalp, itchiness, dandruff, flaking must be addressed either with a ketoconazole or a cyclopyrox based shampoo. You have steroid based shampoo, salicylic acid, tar based shampoos. Keep the inflammation under control. They've also recognized that the hair follicles have a micronutrient and macronutrient requirements. So now we get these rotational vitamins where the vitamins are rotated Monday to Thursday, Tuesday, Friday, Wednesday, Saturday, so that you don't get an overdose, but you get an optimal micro and macronutrient plan. On Sunday, you take your B12, D3. This should be done for at least 3 to 6 months. And then we have a plethora of new molecules for hair regrowth, such as growth factor peptides. You get hexapeptides, bioquinin. There are the signaling peptides. There's so many of these new molecules that can prompt the hair follicle cycle to restart its activity and grow out hair. And then, of course, comes the diet. So balanced diet, like Dr. Niti has discussed and explained, will also help with more protein, of course, in it. So that is hair loss with hair regrowth, and there is female pattern hair loss or balding, which has its own hormonal pathway, which sometimes may require some amount of hormonal intervention. And for both PRP, hair regenera, the technique would help in regrowth. So there's a lot of good news for hair, but it takes 6 to 9 months to show its result. We do use anti-androgens, but very sparingly and as the case merits. But PCOS women are definitely prone to female pattern hair loss. Even at a young age like 18, 17, we see them. So this would be an overview.
Okay, I think we see both the sides, excessive hair loss and excessive hair growth as well at the same time. So one last question to Dr. Pia, and then I think we will wrap up the session.
Ruby, can I intervene for a minute?
Yes, ma'am.
Yeah, we were asking Vinata about some exercises when we are homebound right now for our when she got locked out or there were some issues. So can we take up that question before
Yes,
you?
yes.
Because
I'll just see if she
she
can
couldn't answer. Yeah.
Vanita, are you there?
Vinata, are you there?
Ma'am, she has just unmuted herself. So maybe...
Okay, okay.
Vinata?
Till Vinata comes
I
back.
think she is.
Right.
Yeah.
So
Is Vinata, are you there, Vinata?
It will be otherwise still then you go ahead and ask
I can see
till she joins back maybe. Is she having some internet issue?
Looks like. Probably we request her to send some videos with what exercises to be done.
Yeah, exactly. Yeah, that's a good suggestion.
We will request her to show us some exercises, demonstrate a few of those yoga asanas and all. So the last question to Dr. Pia and Dr. Bhalira would be, to begin with Dr. Pia, now because of the lockdown and otherwise also, the colleges and schools are still not physical like before. So everything is happening online. The sleeping times have changed, the eating times have changed, especially the wake up time and sleep time. People are online till 2, 3. These young girls are addicted now. So, do you think there is a role of, this kind of poor lifestyle, or I would say a circadian rhythm on the entire hormonal milieu? Is there a role of whether stress or this kind of a lifestyle? Does stress play a role?
I mean, I'm going to separate out over here. If we're talking about school-going kids and primarily adolescents over here, like we all know, there is a huge circadian shift, which moves to a kind of what we call a later chronotype, which happens in the adolescent child. And that is actually driven not only by the social changes, let's say the stimulus coming from TV, cell phones, etc., but also coming from a physiological change that is driven by sex hormones. Usually girls get this like a year earlier, possibly as compared to boys. But even if you take out the environmental influences, the disturbances that cause children to sleep later in this kind of age group, even the physiological changes in itself are causing that kind of shift to happen. Now, what results as a cause of that shift is that the children are sleeping later, but the waking up time with schools remaining on time continues to remain the same. So what happens in this kind of adolescent age group is when they require roughly around 9 to 10 hours of sleep, they're instead getting sleep deprived. And it's a well-known fact that with that sleep deprivation comes a fall in grades and academic performance. Especially, it's been found that the attention span during the first morning class actually has been studied and found to be much, much lesser. So the tardiness at work, the getting into class on time, the performance, the academic grades, all of that comes down. Increase in in accident rates has been found also in this particular age group, while at the same time causing mood issues as well, depression to the point of suicidal ideation. So that is one kind of, the whole hormonal milieu that is caused by the reproductive hormones having an effect on maybe psychosocial factors over here. The second thing, of course, is that sleep deprivation and the whole shift. Now, this has been studied better in adults, however, does lead to a decrease in insulin sensitivity because the suprachiasmatic nucleus, which is, let's say, it's called the master clock, actually has peripheral clocks, so to speak, in the pancreatic beta cells in the hepatocytes, in the skeletal myocytes. So all of these peripheral clocks are also kind of rewired, resulting in decreased glucose uptake, decreased insulin sensitivity, resulting then in obesity and insulin resistance in later life.
Okay. Dr. Balani, would you like to add anything to this?
No, I think that's perfect. I think what Pia has said.
So I think that brings to the end of the session because we've answered most of the questions. Everybody, I request everyone to give one last line before we wind up from their end regarding this, whether in terms of treatment or whether in terms of the experience. One line right from each of you, ma'am. Right, starting from you, Dr. Balani.
Well, I'll start with pregnancy. I think a healthy mother will give rise to a healthy baby, and it's a question of generations. So I request all women to look after themselves throughout their lives.
Okay. Dr. Pia, would you like to say something now?
I just feel that the way PCOS is a collaboration of symptoms, I think the more we all collaborate together to work towards our individual patients, I think the better our outcomes can be for everyone, giving a more satisfactory experience to every patient together, not just in our individual blocks with blinkers on.
I think young girls getting a lot of support from older women.
Right.
Okay. Any comment from Dr. Malvika?
Yes. I'd like to say that PCOS has become something that all of us, all dermatologists have now understood. It's something that is in our practice every day, all the time, with all its different ramifications. And I think we have become better at not only treating the signs of hyperandrogenism or insulin resistance, we're also giving a very nice overall, long-term maintenance to our patients, because we do know that the acne can come back. We do know sometimes the hair fall may start again. We do know that if you discontinue their metformin, their weight may go up a bit. So I think that there is a very good, now we've understood it much better to be able to give our patients long-term plans for looking after themselves, their weight, their lifestyle, and therefore keep their acne under control, prevent relapses of hair loss and hirsutism. And that's why we now have much happier PCOS patients who earlier were very depressed and felt very low, and the aesthetic concerns really bothered them. I think we have much better options with long-term solutions for them. And that actually has been a very good progress in the journey of PCOS over the years.
Good improvement. Is Vanita there? Vanita, are you
Vinata.
joining?
Yeah, Vinata is there. I think she has connectivity issues. I think she was very much there.
You can see her, but she's not able to visible.
Yeah.
Ma'am, I think a last word of wisdom from you, and then Jayshree ma'am will give the formal vote of thanks. A final word coming from you, Niti ma'am.
Well, I mean, one, as Dr. Pia mentioned, it's a multidisciplinary approach, and healthy diet is not something that always has to be boring. There are simple tweaks and tricks where you can still eat tasty food and still have a healthy diet, which will kind of help you with the whole PCOS scenario.
Okay, thank you, Niti ma'am. I really want to thank each one of you for sparing your valuable time. Your inputs are really, really valuable because a patient has to see all of us for the best outcome. And once a PCOS, always a PCOS is what we usually say. But we have better outcome treatments now. So it is all thanks to each one of you and each society like Indian Diabetic Association, PCOS Society, helping the patients at large. I want to give a formal vote of thanks. So I request Jayshree Paranthi ma'am, who is the Vice President, co-convener of Indian Diabetic Association Mumbai chapter. Over to you, Jayshree ma'am.
Yeah. Thank you, Ruby. Indian Dietetic Association Mumbai chapter will like to thank Dr. Duru Shah, President PCOS Society, for agreeing to collaborate with IJ Mumbai chapter. Now you all have made it very clear that to treat PCOS, for that matter, any lifestyle disease, it is always a teamwork and team effort, and all of you have You have made our resolve very strong about it, that it is always the teamwork which makes the trick. So thank you so much, Dr. Pia. You made PCOS sound so clear in everybody's mind. Your inputs were very to the point and very, very practical. And that is what the young budding dietitians need when they are looking at patients' papers, because many a times so many things may not make sense to them, why some tests are made, why they are and how to read those reports. And that is very, very important, being a therapist. Dr. Malvika, you brought out some very good facts about the skin and hair treatment, which is very, very close to the heart of any woman. So thank you so much for your input. Banta, we somehow couldn't connect with her for a very long time, I suppose. So we will get the videos from her. We will request her. She can suggest few, especially those which we can do at home when we are really uh, under house arrest, so to say, because of this COVID pandemic. And I'm sure she must be having some exercise suggestions for us. Niti, thank you so much. As always, your presentation was so very good. And our dietitians will definitely, they have taken some good message from that. We will fail in our duty if we don't thank our tech support team. Prachi and Kasturi, both of them are also young dietitians, but they always, take care of the back end. And because of them, we are able to conduct these programs very well. She is ably led by Sukada. She is our treasurer and the leader of our tech support. Our convener, Zamrud Patel, she always encourages us, gives us support to conduct such events and programs. And not last but the least, n- Ruby Sound. She is the host of today's program, and she is the secretary of Mumbai chapter. Thank you, Ruby, for hosting and for conducting this question and answer session so beautifully. Once again, thank you so much. And I hope the association with IDA continues, and we will bring out some more programs in future. Once again, thank you.
We also look forward on behalf of the PCOS Society to greater working together. Thank you so much.
Thank you. Bye. Bye, everybody.
Thank you.
Bye. Thank you, Dr. Priya. Thank you, Dr. Malvika, very much. Dr. Sarita, thank you so much for your presence and your time.
Thank you,
That was
Niti.
excellent.
Thank you,
Very good.
Indian
Yeah.
Diabetic Association and PC.
Yeah.
Thank you.
Thank you, Ruby. Thank you, Kasturi. Thank you, Prachi. You've been the saviors. It wouldn't have been possible without you.
Always welcome, ma'am.
There are so many hiccups, but you kind of took us through.
Anytime, ma'am, anytime.
Absolutely not possible. Yeah. Okay.
Just end meeting for all.